Hello, and welcome to All In, recognizing innovation's vital role in helping providers improve access and outcomes, co-presented by Accenture. My name is Angel Moore, and I am Special Events and Committees Manager at Community Health. Community Health is the largest volunteer-based free health clinic in the United States. We provide primary and specialty care, prescription medications, mental health and dental services, health education, and labs, including COVID testing and vaccines on the west side of Chicago. Our patients have no health insurance, and we provide all of our services to them at no charge. We do this with the support of over 1,000 volunteers, partnerships with dozens of institutions, and donations from generous people like you. Thank you for being here and for supporting Community Health. I would especially like to recognize our many sponsors who are supporting this year's All In series, including Baxter, AbbVie, Lundbeck, the Joseph and Bessie Feinberg Foundation, West Monroe Partners, and many others. I encourage you to visit our website, allin-chicago.org, to see the complete list of sponsors, read the bios for our incredible speakers, and check out the rest of the month's events. Finally, I want to recognize this year's All In Executive Leadership Council. We have the privilege of having 4 outstanding leaders serving on the council this year. Their great insights and support have been instrumental in bringing this year's series to life. Thank you to Dr. Jay Bhatt, Mark Ishog, Brian Marcella, and Dr. Julie Merida for your contributions this year. You will hear from one of the members of our Executive Leadership Council, Dr. Jay Bhatt, as a panelist today. The goal of the All in Chicago series is to bring together leaders from many different industries and segments of our population to talk about how we can work together to ensure every resident has access to the right care in the right place at the right time. Community Health has been hosting All In events discussing access to healthcare in Chicago since 2015. This year, as we continue to navigate a global pandemic, the conversation around access feels as relevant as ever. COVID-19 has brought on not only public health challenges, but concerns about the accessibility of healthcare. How can technology help us bring the care to the patients? How can innovation improve the quality of care? Today's panel will address these questions to help us move toward a future where everyone in Chicago and beyond can access the best possible care. It is my pleasure to introduce our moderator for today's event, Asher Perzigian. Asher is the Managing Director at Accenture Strategy and Consulting, the organization who is co-presenting with us today. Accenture delivers on the promise of technology and human ingenuity. They embrace the power of change to create long-lasting value in every direction for our clients, people, and communities. With no further ado, I'll hand things over to Asher to introduce our panelists. Thank you so much for being here, Asher.
Thank you so much, Angel. It's a huge pleasure to be here, and I'm extremely proud to introduce this amazing panel today, who are some of the best minds in healthcare in Chicago, focused on really improving how we as patients get and receive care. So to start off, Dr. Jay Bhatt, who you briefly heard, has a very important role in helping shape what Community Health and All In have been driving over this series, is a public health physician who represents some of the national as well as local stage here in Chicago, focused on improving access for the most vulnerable populations. Currently, he's also an active practicing physician, as well as Chief Clinical Product Officer of Medical Home Network. Welcome, Jay. Amy Ross is the Senior Vice President of Strategic Planning and Service Lines at the University of Chicago Medicine. In this role, Amy directs the implementations of the organization's 2025 strategic vision, as well as the expansion of the ambulatory network, and oversees heart and vascular, digestive diseases, and other critical service lines for the patients. Meredith Sefa is Vice President of Strategy and Operations for Clinical Care at Providence. Meredith has a fantastic track record of implementing some extremely strong technical solutions as a clinical informatist for organization-wide strategies that they transform how care is given to patients. And finally, certainly not last and least, Lydia Splan serves as the Senior Vice President of Access for Northwestern Memorial Healthcare, where she oversees the entire system's physician referral services, central scheduling, financial counseling and clearance, as well as admittance and registration. So with no further ado, please welcome all our panelists. Before we get started, while this Zoom call does not have live chat for everyone, we do have a chat function at the bottom. Please submit your questions. We will absolutely try to answer as many as possible. With no further ado, Amy would love to kick off this discussion with everyone here with you with the question on what is your organization currently pursuing to improve access and outcomes for patients in the University of Chicago medicine system?
Sure, thank you. And thank you everybody for inviting me today. It's a great honor to be here and with the panelists and with you. So happy to share our experience at University of Chicago. So, our community, obviously is so important to us in the South Side of Chicago. And the way we organize around our health and equity is under our Urban Health Initiative, which is run by Brenda Battle. We put a heavy emphasis on health and equity as we think about the communities we serve, and also about how we think about our partners in the South Side. So through collaboration with civic leaders, with some of the community organizations and other healthcare partners, we've developed a mechanism to really create a conversation around health equity through our Southside Healthcare Collaborative, as well as providing grants to those faith-based organizations and CBOs in our market to really try to drive access to healthcare in that environment. So those grants will support things like community healthcare workers and really push the envelope on how we can make sure that we are staying aligned in that ecosystem to drive equity and access. In addition, this year has been exciting for us because we were part of a collaborative of 13 organizations, including FQHCs and other hospitals and systems, to bring about the Southside Transformation Project through the state that gave funding to really try to drive access, equity, and performance for healthcare. And as a Southside, we came together in a pretty pivotal time in our tenure there down in the South Side, and really to think about how can we drive and change the ecosystem and make sure that we're giving all access to our patients and to the communities we serve. So we were given $25 million next year to create a community health organization that will drive community health care workers, and a couple hundred of those primary care and specialty care in our communities through an IT platform. So thinking about innovation and how we're going to drive access and really bring together a new ecosystem of care on the South Side. So that's it.
Thank you, Amy. It's very encouraging to hear all the work that you're currently doing and more importantly, invested in for not just Chicago, but how to think differently about healthcare. So excited to see how that comes into fruition. Lydia, as SVP of Access, you certainly are the central hub of care delivery. As within your role, both at Northwestern as well as what you have seen more broadly as trends, what barriers do individuals and organizations face as they think about care innovations around access?
So that's a great question. I would say COVID really was an accelerator for many of us in our innovations around access to care. And like many others on this panel, nationally, locally, we really went deep into planning for remote monitoring of patients and telehealth. And a lot of the barriers that we have encountered and continue to work through is really the uncertainty of the future as it relates to payer contracts and the environment around the regulations for seeing patients across state lines. Each local and state, or each state government has their own licensing rules. So I think that's an area that we're digging into right now. And then the availability of patients and their technical expertise and how they utilize technology and how well they understand technology. So we've spent a lot of time trying to reinforce and provide help to patients to navigate this sort of new landscape. So I would say generally, we all seem to be on a path for greater meeting patients' needs where, when, and how they desire. And that is going to be largely through a lot of the technical innovations in virtual care and remote monitoring. But I think the regulatory and payer environment, as well as the technology savviness of patients and physician willingness really to jump in and shift their panels or shift the way that they're seeing patients, is all factors in how to embed it into just a daily operation and a way to think about expansion moving forward.
Thank you so much, Lydia. Dr. Bhatt, as we think about what Lydia was saying with the trend of serving patients where they are, as we think about moving the spectrum of virtual care from the initial question of do we have it or not, from an access perspective, whether it's primary or specialty, to the other side of the spectrum of we do full-based hospital level care at home. What access challenges are you seeing in your role across different populations as it relates to serving the communities you serve?
Right. Thank you, Asher, and just really an honor to be with this esteemed panel, my colleagues, and appreciate their great work. And thanks to All In particularly Community Health, for their leadership and work and pulling this series of conversations together, which I think we've learned a lot from and can help move us forward on a number of issues. So in clinical day-to-day care at a community health center, I see the access challenges related to lack of education, literacy, social, economic, environmental factors, and that shows up in a lot of different ways. It also shows up in the way that people maybe prioritize how they think about health in their lives and in their families' lives. And when we think about it in the work at Medical Home Network, it's really around delivery redesign. And Medical Home Network has been committed through the model where it's enabling disparate providers of the safety net for vulnerable populations to work together in an integrated fashion to provide better whole person care across the continuum that really tries to drive down total cost of care and provide access points, meeting people where they're at. And that's in-person, virtual, digital, and practice innovation also is transforming the way the care is managed at the practice level. So there are care managers, care teams that are trained with structured workflow processes and have access to a technology platform, MHN Connect, which helps them deliver the kind of care that people need at the place that they need it at the time that they need it. And we know how people are moving, across various parts of the continuum. And then there's eConsult, which helps try to get specialty access to folks that need it. And then, patient engagement on building relationships with patients with sustainable trust with care teams that go beyond the four walls of the practice. So in their homes, where they experience their lives. And then not only addressing the health inequities by closing the gaps we see by increasing access and quality of care for safety net populations, also thinking about how do we create more opportunity. I think we think about equity and disparities from a closing a gap perspective, but it's also I think about how do we create opportunities so that those opportunities then end up closing the gap. And I think that we've in our work with COVID and looking at AI, using all the platform data we have, the health risk assessments we do, we're able to merge that data to identify folks that were socially isolated or people that might deteriorate quickly and proactively go upstream and access and provide access not only just for clinical care, but other needs that they might have. And then I just end with saying that one thing we got to continue to keep in mind is digital literacy. These populations that we care for have challenges with it. And so we need to think through how we how we do that in a way that, they're able to access that.
I would echo that comment on digital literacy. I think we're finding in some of our early research, Dr. Sachin Shah just produced something in Health Affairs a few weeks ago that was to that end about how, we can create the access and the technologies, but making sure digital literacy, broadband at its very core is in the right neighborhoods, and those types of elements are available to make sure that we don't widen the inequity or equity gap, however you think about it, right? So we have to really think about what that means and making sure that we don't continue to perpetuate that. And how do we make sure that we're developing the operational systems and education to make sure that we're continuing to drive that down?
Excellent point, Amy. One thing I would add to that as well is as these systems are being designed and the functionality is being developed, we often think about utilization and not necessarily the most broad spectrum of how that can be received. And what is fascinating and interesting, whether or not it will be effective, is we continue to see non-traditional players utilize their infrastructure to try to deliver care. Whether you think about on the way outside of healthcare, what Facebook and Google are doing in some developing nations and countries across the world with setting up satellites and other technology to provide connectivity so that you can ultimately get a device in someone's hand they're solving one problem to support what their need is. And I think if we think about how that can derive into what we are thinking about from a health perspective, that is more and more entering kind of the forward notion of how we think about health technology. Meredith, as a clinical informaticist and a strong history of marrying that with strategy, as Jay mentioned, care innovation is real. We are changing how our care models are designed. As those begin to transform and non-traditional players enter and position themselves in the market, how are you navigating, both digitally and physically, the new ecosystem of healthcare? And what does that mean from an access perspective?
So I think, it's, you see all of the, obviously COVID was a terrible thing that has continued to happen to the world, but you see all of some benefits that have occurred for healthcare from the perspective of opening a lot of doors. And I see this just interesting convergence between all the kind of fits and starts of value-based care moving forward over the years. And many of us trying to say, well, okay, we need to do things differently in care teams and, reduce readmissions, all of those things in order to care for our patients and, at a high quality, but at a lower cost. But many of us are still fee for service. And COVID has kind of opened the door for some of the necessity of caring for patients differently that happen to align with value-based care in an interesting way. So, in IT, many of us were trying to push telehealth forward for many years and trying to get operational stakeholders to buy in. And obviously, because they weren't paying for it, people weren't as interested, but we also saw it as a great way to help with access. Same thing with e-consults, as Jay had mentioned, for areas like dermatology, where it's very difficult to get a dermatologist appointment. And with COVID, then we had 6 weeks to launch it, to get telehealth ready for people. And so I think that it's also opening the door for kind of having like electronic care navigators, if you will, where we can kind of monitor the patient, post-discharge, for example, for a couple months if we need to just make sure that they're doing okay. And I think, not only have providers, but patients have gotten more comfortable with this idea of being remote, being on a Zoom. So therefore they might be comfortable with a video visit. So I think that we have a little bit of a window here to help move toward value-based care in a way that people are a little bit more open to. And I think the last year has really just kind of forced providers and patients to be more comfortable with ambiguity and change and trying new things. And I think that has allowed us to more easily say, hey, let's just try this and see how it goes, especially with trying different care models so that we can help the different risk groups within the way that they need to be helped.
Yeah, and I would add to Meredith's points, which I completely agree with, is that the payment model has to follow the care design model, not the other way around, which is often what we see, right? And particularly for vulnerable populations, also making it easier in terms of the on-ramp for folks to take risk and move towards value-based care, and the technology, being an enabler of that care model. And to your point, Ashley, earlier about lived experience, I think that's what builds trust, is, how are we using lived experience to inform the care we deliver?
As a clinician, Dr. Bhatt, what friction are you experiencing from your colleagues or those you see in the broader community, broader national conversation about that shift in payment model and hesitation as we think about really what the next generation of the provider-payer relationship is?
And I think one, we're seeing more of it accelerate into the points that have been already raised. COVID's helped on some of that, but it's still, I think, from what I've seen, is hard for people to leave what they know and what is predictable to go to a place that requires leadership, infrastructure, stakeholder engagement, organization, and particularly around areas when we think about mental health and substance use, as well as maternity, and chronic disease models that haven't been designed and paid for in the right way. I think that's a hard thing for folks to come onto. Now, with Medical Home Network, we've, with 13 FQHCs and health systems, we've shown that, over the course of 4 years, we're able to improve outcomes, lower total cost of care, save $80 million in a shared savings arrangement through an ACO, and return that back to the members. But that requires the infrastructure, the leadership commitment, the technology, and all the folks sort of being on the same page and then evolving with it. I think CMMI is the next 10 years it's an inflection point for the Centers for Medicaid and Medicare and Innovation to take what we've learned, take this moment and move towards, designing the care models and then the payment models that support it, and condense the models from what we've seen. Think about the integration with states, and there's a big focus that they have had on equity. So, we'll see that much more strongly embedded within the care model development and demonstration process and evaluation process.
Yeah, and to Dr. Bhatt's point, I mean, our hope is that if CMS does adopt payment models that support care models, other commercial payers will follow that as well. And so there are certain no regret paths. And I think telehealth and virtual care and remote monitoring is kind of out of the bag and it's not going to go back in. So now I think it's a matter of how we use our advocacy and other models to really force is not the right word, but encourage these models and these, emergency mandates to stick in a longer way. I think a lot of hesitancy we're seeing as we're building telehealth more firmly into physician templates and allowing patients to self-schedule whether they're going to do a virtual or in person is the hesitancy by physicians is not really knowing the long-term outcome of how long that will be reimbursed or at what level, and that causes trepidation for providers as they are really looking at their next 6 months, year of activity within their clinical panels. So I think that it definitely is necessary to get to a point where we have some more assurances or models that have been approved around the payment that follows the care that people really desire.
I would also just add, in a similar way, Lydia, I think, we had a similar problem at UFC and when we first got telehealth and virtual health launched, making it part of their practice, right? Whether it's in their templates and getting them to be mindful of how to engage with it, getting the technology caught up to the operational components, but making it part of their daily practice with those templates is critical. I think being in large AMCs and health systems, culturally, it's sometimes harder to get things over the finish line. And I think we're in a way thankful for the push that came from where we were at the last couple of years. But I think, it has been somewhat challenging, and I'm glad that it's out of the bag, and I think we can continue to push the envelope.
This is a fantastic topic, and one that as we think about change management and we think about culture and what it means to deliver care, as we think about the early front part of the funnel into medicine, the way we are now teaching clinicians, be it med school or other, is a completely different approach to medicine. And I am excited to see how the next generation of care providers will be able to merge that intent for business strategy and what's best for patients, as we are all clearly in this industry because we are mission driven, with also easing up on the fact that when we talk about innovation, that's our sweet sauce. How can we, as both mission-driven care providers, be it on the admin side or with the patients, think about releasing those innovations and that secret sauce of our organization to the community? So the question to all of you is, what innovations do you experience as part of your organization or within the broader community of another organization that you'd like to see implemented more broadly, whether it's with a partnership organization or whether it's a community-based organization, such as CommunityHealth or a number of the FQHCs or ACOs that we see throughout Illinois and the nation?
I can give a couple of examples. I think for me, the holy grail of being able to innovate in the healthcare space is having analytics that are curated and have come to some kind of conclusion, like a risk score for sepsis or risk score for readmission, and really porting that answer to a very complicated question back into the clinical workflows. So, you know, when I was at North Shore, we did a few of those with like identifying all high-risk patients based on a very complicated algorithm that had age, comorbidities, many other things. And then it just gives you one answer, yes, no, you're high risk or you're not. And putting that into the clinical workflows for the right people to see at the right time, whether it be the social worker that then has a whole care plan that they follow for high-risk patients, or the nurse that then knows that they have to do something different for that patient, or the provider in the ambulatory space once the patient is discharged, so that they know that they can review all the care plans that are in progress with the social workers. I think taking the heavy lift, you know, out of the provider's day and doing whatever we can to put all that information together, because, you know, the providers are so overloaded with information constantly, and then giving that opportunity to react to something important, I think is really huge for moving care forward. And, you know, and same thing for value-based care. So I would really love to see, just in general, people leveraging that opportunity, which I think people have not always necessarily married those two yet, the analytics that's happening, and then actually putting it back directly into the EMR where the providers can see it. I think those things are all happening, but they're not being tied together often enough. And that's what I would love to see happening more broadly.
And I think to build on that comment, Meredith, I think the piece about bringing all of it together, whether it's through an HIE and giving transparency to not only the institution that you're in with those providers, but more broadly, right? As we think about our community partners, the CBOs, the community healthcare workers that are out in our communities, and making sure that everybody has that availability of the data they need. Are you picking up your prescription? Are the patients engaging? What is your current readings in your blood pressure monitors? And then that travels back to the clinician. So I think, you know, as you think about that as an example, I think there's an ability, as you think about the future and who has done that well. I know there's some Parkland and Citywide and some of the others out on the East Coast and down in Texas have done an excellent job of bringing some of that together to really get information out, not like from a data perspective across an entire community, to make sure that we're taking care of those patients holistically. I think, Asher, one more comment, actually a couple more comments. The other would be when you talked about medical students and innovations and bringing up fellows and education, you know, an example that I actually thought of when hearing that question was, you know, they're engaged. You know, we have a lot of our medical students and fellows during the COVID-19 pandemic that were reaching out and developing apps real time. We were working with them to try to get information to our clinicians as information was coming out daily, hourly on what to do on PPE. We had a fellow who I was working with to develop an educational app for all of our employees to keep pushing out information so people could get it on their phone, download the app, and get the information, because, you know, is it a mask? Is it not a mask? All those questions were coming up and changing so quickly. And then who to call in the organization if there was an issue. So those types of partnerships were critical at that time. And I'd like to see that continue as we think about innovation in the future. And then lastly, my other comment would be, you know, innovative models as we think about, you know, what we've implemented in our communities. You know, I think we can all recognize the issues around gun violence in our communities, you know, and I think UCM has taken this in-house, and as we think about violence recovery. And I think this is a model that could be, you know, in urban centers around the country, and really thinking about how do we recover after trauma. We are seeing, unfortunately, we are being inundated with additional trauma across, you know, the city of Chicago, especially on the South Side. And how do we continue to amplify the voices and use those violence recovery specialists to really make it a dramatic improvement and not perpetuating the gun violence on the South Side? So those are some of the other innovative models we've been working through.
So I would add, and that agree with those innovations. Those I think are all important. And, you know, I think the Southside Collaborative and that work on transformation is a great model along also with the work that's happening on the West Side. But, you know, I would say that we can't improve what we don't measure. And so, you know, numerous states are now utilizing measures that actively monitor health inequities in Medicaid programs. So Michigan, for example, is publishing 13 measures by race and ethnicity publicly, while assertively pursuing reductions in disparities for low birth weight infants, while California and others our reporting measures for seniors, disabled individuals by race and ethnicity for MCOs. And then these measures can be incentivized directly under alternative payment models, and Oregon's use that approach. And when we think about the rural health challenges, those are significant as well, not so much necessarily in Chicago, but if we certainly go outside of the city and the county, but there's learning we can take from that. The Pennsylvania rural health model to address access and sustainability issues, was one where applied what Maryland had done from an all-payer model standpoint to reduce total cost of care and applied it in the rural setting. And we've seen some interesting uses of the Medicaid waivers. For example, in North Carolina, they pursued a waiver that included institution for mental disease waiver pilots, to address some of the targeted health-related needs folks have. And, I would say that one of the ways we could think about how we might work on the Medicare population, so the post-acute, the people in skilled nursing, long-term care, and supportive living. One of the areas of work we've done at Medical Home Network is through More Care, the Medicare Advantage Health Plan. We're focused on the special needs populations and working with a provider group, and we're able to reduce hospitalization rate 81% when compared to fee-for-service Medicare beneficiaries. So I think for community health centers and for the safety net to have a Medicare strategy is going to be particularly important, and in partnership with health systems and hospitals in the places that make sense. And then also, given the American Rescue Plan and some of what's come out of that, there's also opportunity around what's coming in annual enrollment, particularly with the marketplace and folks that may not be qualifying for Medicaid, but and may not have qualified for the marketplace before, can now potentially qualify for it, given some of those provisions. So, ensuring that we get people, as covered, and then help educate them on how to use the care that they have, and then continue to use the various, technology tools as appropriate, and educate around the challenges that vulnerable populations have with digital. I have patients that tell me, look, I'm not going to use this app or this particular tool if it doesn't actually really help me and it's meaningful, because it costs money, because not all of them have unlimited data plans on their phone. And so text messaging works pretty well, but that may not use all, and remote monitoring could be really helpful.
Yeah, and Asher, I think getting back to just probably more basic answer to the question with, what innovations do we hope do continue to persist? And again, I hate keep going back to telehealth, but I do think, every year we do a community health needs assessment, and we narrow in on our activities in support of the community for the next 1, 3, 5 years. And those buckets generally are access to care, economic and workforce development, as well as community engagement. So in that access to care, I think the innovations that we learned in the remote monitoring and telehealth space should not only persist, but expand. For example, in our work with the community house and specialty coverage, if we can have specialists being, high demand specialists who have very busy practices, but are willing to intervene where they can in the community, and where we can build that infrastructure to make that easy for them to port into an exam room with a primary care physician in a community environment, or do an e-consult between 2 physicians who's just checking thinking on a particular topic. I think that's a very practical answer to the innovations we've seen in the past year and a half, and how they should persist forward, and how they should really become integrated in the care models and the abilities for specialists and community care providers to continue to collaborate in areas that may not have easy access, including the rural environment, which I agree is oftentimes in our city of Chicago, not necessarily a hot topic, but those needs are oftentimes amplified, or at least at the same level that we see in the city as well.
Lydia, I think that's a absolutely fantastic point, and
I think we lost Asher.
it brings us back to and you very appropriately brought up providers. Am I back? Thank you. So I apologize for my internet. Lydia, you had mentioned appropriately that sometimes providers don't have access to the tools they need. What we saw 10 years ago with big EMRs such as Epic and Cerner, who would enable smaller versions of their software for community PCPs or others, so that they could have that relationship and the flow of information with the hospitals. I think that's absolutely true as we think about remote monitoring, as we think about telehealth, as we think about that access. Where have you seen that friction, or where have you seen successes as it relates to either resistance of doing something, or a relation of resistance to doing something because we aren't educated and what that means?
Sorry, coming off of mute. So can I repeat the question? Because it started. So with the providers' willingness and or resistance, or the access to tools that they need, you were asking what the barriers are that we've seen?
Correct.
You know, I wouldn't say it's not dissimilar to barriers we see within our patient or employee populations. I think it's all about change and change management, understanding digital platforms and how to use those tools to their maximum ability. And I think in roles like Meredith's and others, where you have people who can go out and assist with, here's the workflow, here's the barrier, here's the particular technology that could maybe help overcome this problem that you are seeing. We have an annual fun exercise called the Pebble in the Shoe, and we go and talk to all of our healthcare providers and our physicians about what are those things that are just irritating and irritants that bother you on a daily basis, that prevent you from really wanting to do this or do that, or use this or use that. And I think we hear a lot from them when we ask them on what are their barriers or what are the resistance. And then we work to form ways to, provide education or assistance or modifications. We have a whole innovation team that will work with a technology called Artisight or Whiteboard, and they will work with physicians on something as simple as OR start times being automatically noted because a patient rolled into the room and Artisight picked it up and documented it for them. Back to Jay's point on the data and the accuracy of the data and the reporting of the data, in order to, as a starting point for many of these innovations and overcoming many barriers or issues operationally that we see every day. I think it's really engaging physicians to help problem solve and tell us what really are the problems, instead of us sitting thinking about what the problems may be for them. So I would say mostly getting out of our own way and being collaborative with our caregivers, and they tend to have better ideas than we have. And they also tend to then want to help problem solve more issues. I don't know if that exactly answered your question.
It did, and I appreciate your perspective on that. And I absolutely love the phrase, and we'll steal the phrase "pebble in the shoe." So thank you for that tidbit. I think a lot of what our conversation with everyone has revolved around is, as we think about the future and the path that we've been accelerating on over the past year, where are we seeing the industry going? I would ask everyone, in addition to education and equity, what else needs to be true for us as a community to realize the goals that we've mentioned? And more importantly, or equally as importantly, what conversations around those points are you and your colleagues currently having within your organizations to drive change? And Amy, if we could start with you, knowing that you lead your 2025 vision, I would love a peek into that as you can, outside of confidentiality, of course.
Sure. So I want to make sure I got it too in terms of the question. So, it was a long one. So the first, the first part of the question, I guess, as I think about where it's going and where the predictions, I think is the first part of your question of, not only, I think we all could agree on this panel that virtual is here to stay, and it's going to continue for the next, into infinity as we think about virtual health. So I don't think any of us would argue with that. I think as I think about the predictions of the future, as we talk about it in some of the conversations that we're having, is the transition of care from inpatient to outpatient to post-acute to hospital at home is sort of the new conversation, right? How can care evolve in those lower acuity touch points in those various on the continuum of care? How do you continue to evolve the care and meeting patients where they are and where they want to be cared for? So I think that those are some of the early conversations we're having at the University of Chicago, given some of the push towards even hospital at home and some of the services outside of the hospital. And I think, the folks have talked about remote patient monitoring. What does that mean? Obviously, it's complex for a lot of reasons, but I think as we predict the future, I think those things will become more commonplace. I think the other thing that I would like to see in the community, which I think is the second part of your conversation, is around transparency. I think so much can be gained in our communities, whether it's the South Side, whether it's the West Side or the North Side, in transparency of data and medical data. I know we're moving in that direction, but I do think there's a huge benefit to the patients, to the providers, and really communicating not only within the healthcare sector, but then with our CBOs, FQHCs and other partners, community health, et cetera, in really trying to drive care and improve care and meet patients where they are. Did that answer all of your question? I think I got both aspects.
It did. Thank you.
Yeah, I think to add on to what Amy said at the beginning, I think the reality is that whether or not it was like 5 years ago or it's going to happen in the next 5 years, at some point in that time frame, every healthcare organization is realizing that for 100 years, the hospital has been at the center of everything. And now, in order to be successful, we need to move the patient to the center of everything. And so I think that a lot of what conversations that I think organizations are having right now is, number one, they're looking at their structure. Are they siloed between, ambulatory care and hospital care? What does that look like? And I think there's a lot of kind of like, fiefdom, that you have across organizations of like, no, hospital care is mine. That's where all the revenue is. No, the ambulatory care is, we make all the decisions. And there is no way that anyone will be successful unless those silos, whether structure wise or just relationship building wise, are removed, because the only way to be successful now for the patient and for finances, frankly, is for everybody to do a handshake about points of care and decision making, and everybody has to give and take. And that, that might mean moving some resources that used to be in the hospital to ambulatory or vice versa. And that's very complicated and difficult culture-wise for everybody to get rallied around. And the places that I've seen that be successful, whether that conversation has already started or is just starting, is very top down, and it has to come from the top. And so I think the organizations that will be the most successful are the ones where the top level executive team is saying, we are one, regardless of how big you are as an organization, and the patient is at the center, and we are going to follow that patient, and we're all going to work together to do it.
I love your comment about that. And one thing that I've seen with several organizations I've worked with is the only way for that to be true, in addition to one voice, one team, one executive commitment, is it has to be at scale. When we see organizations try to pilot a new type of care or a new type of operating model, it may exist comfortably in your very secure pilot. And then when it's released to the beast of the organization, it will immediately crumble. And to, as you mentioned, Meredith, have that gusto to completely ask ourselves, what do we want to be over the next, not just decade, but 2 years? If that is not decisive and that is not all hands stacked in, let's make the commitment, we'll see it fail. And I'm going back to the conversation of non-traditional players entering the market, accruing very expensive patient services, accruing dialysis, doing various things from a bite by bite piece, whether it's a small organization or whether it's a larger organization, such as Amazon with Amazon Care, finally realizing that it's not just a virtual play they're making, but they're heavily invested in both the physical as well as the virtual, or what you're seeing with Walmart or any of the number of organizations. that's scary to providers. And I think providers need to respond quickly to be part of that conversation. And community care, at home care, is more interestingly a nicer answer to how providers will be able to sustain.
Yeah, I think just one last comment I'll add to that is that I think especially the larger providers and in every, everyone's getting gobbled up, right? So everyone's becoming some version of a larger organization. I think the healthcare organizations know that none of the Amazons we can't be beat as providers if we work together and do it right, because they are all individual parts of what a patient needs. And as organizations that have all the pieces, we will win if we work together and work toward these kind of 2025 goals. Amy, we have the same exact kind of, project going on where you have these like transformational goals, and we know what we need to do to get there. We just have to do it.
So I would just add several other elements to the wonderful comments already made. One, I think a focus on affordability, and that's out-of-pocket costs to the consumer, because that is going to be a issue to compete against, and an issue as other non-traditional players are in the market. But we've got to continue to push costs down. The other is the trust and how we build it, not just between patients as patients and families at the center, but also within organizations through culture, within leadership, administrative leadership, and clinical leadership, where there's a gap that needs to be closed between different components of the workforce structure, and that goes to workforce development being another one, because you're going to have to train and upskill folks differently in order to transition, and it's sort of perform while transforming is part of what organizations are going to have to continue to do. And then I think organizations figuring out how to drive forward their roles in communities with diversity, inclusion, and equity, where diversity and inclusion isn't the final destination, health equity is, but you need diversity and inclusion to get there, so that organizations have the best ideas, the best conversation that lead to the best decisions and outcomes.
I wouldn't leave out the payer side of this as well, in terms of, as we think about, the next 3 to 5 years, I think some of our challenge historically, which I think folks have alluded to on this call, is the reimbursement isn't there to drive, new care models, right? And there's always this balance, whether it's government or commercial. And I think as we think into the future, how we're paid as providers, and really understanding those partnerships and really thinking about that as well, because I think Meredith, you had said, hospitals right now are incentivized to keep those people in the hospital for the most part. I mean, if you think about the Chicago market, we're still, upwards of, 90-95% fee for service, right? And then there's a lower value-based care. And hopefully as that transitions over time, we can continue to build those partnerships. But I think understanding the payer landscape and how that will evolve will be important as well.
Yeah, I mean, I'll just chime in on the sort of future predictions. And I think all of you have said various parts of it. And I think I liked Meredith's comments a lot on structurally health systems organizing themselves to be singularly focused on connecting the care across the care venues in a way that has the right information at the right time for the providers, but also is how, when, and where patients want it. And that really does start with a cohesive team that feels very incentivized towards making that happen. And to Amy's point, has to be considered within the payment and reimbursement models, because, and I'll just tie it together with Jay's comments on, increasing costs or making affordability work. All of those things kind of have to, the strategy of the organization, meeting the desires of the patients and their providers to want to change models and do care differently, but also with a focus on the reimbursements so that you can fund those strategies, because it is a multi-part puzzle that we're all working in all the time to try to get the best care of the patients with the best outcomes at the right price. And all of those pieces really have a lot of external forces that we all grapple with that we don't really have control over. So I think what you can control is your internal strategy and the work you're doing to set up your org structures and your accountability structures within your organization, all driving towards the same goals. And then hope that the market is also moving in tandem to pay you for those activities. And then also, I think Jay is absolutely right. The diversity and inclusion initiatives as it relates to health equity, I mean, that is a huge topic around Northwestern all the time right now. How are we bringing in community teenagers and, you know, late teenagers to do internships and grow up in the healthcare environment? And how do we start investing in, or how to not start, but continue investing in the growth of the communities we serve, so that over time, our environment becomes more and more diverse and reflective of the communities we live and work in. And then how do we make sure that that then translates to the health equity outcomes? I think more and more the younger generations coming in too, they're just passionate about this. And it's not that we aren't, and we've been in healthcare for a while and we've been pushing that agenda, but I think it's going to be a non-starter for anybody coming into this environment, for organizations that aren't focused on both diversity and equity, but also environmental outcomes. I think we're seeing, if you don't have an environmental outcome agenda and you're not talking about green energy and you're not talking about sustainability and you're not talking about those things, you're not going to attract top talent, because they are interested in working for organizations that equity and diversity and inclusion and sustainability are at the core driving strategies. So I think there's a lot of factors at play here, and it's retaining and attracting the best talent, and that talent is very interested in those topics while we're trying to, you know, sustain in our operations through, you know, getting paid for services, while we are, you know, meeting evolving consumer expectations as it relates to convenience, frankly, and the ability to interact with us. So certainly no lack of challenges across the board to continue to grow and meeting our mission driven for patients first.
Well, Lydia, that you had a perfect wrap up, I think, to this very important discussion as we think about balancing how we simplify and personalize the consumer experience while broadening access and outcomes. It's an exciting challenge for all of you as executives with your large teams across some of the most prominent healthcare organizations in Chicago. So as a Chicagoan, on behalf of us all, thank you for everything the four of you do tirelessly every day to improve our care of the future. As a patient, as a father, as a caregiver to aging family members, that's very important. This conversation energizes me and excites me about the future, knowing that what we are solving and what you are all leading is going to be very exciting. With that said, Angel, we will pass it back to you to wrap up this discussion for the evening.
Thanks so much, Asher, and thank you all of our panelists for today's conversation. It was such a good interactive one. As mentioned earlier, today's program was brought to you by CommunityHealth. All of your ticket sales and any donations made today will support CommunityHealth's mission to serve those without essential healthcare. Please consider making a contribution now to support CommunityHealth. Instructions should be appearing on your screen, and a link will be dropped into the chat. On behalf of the staff, board of directors, and volunteers at CommunityHealth, I want to thank you all for being part of our All in Chicago event series. I hope that you are all leaving today with ideas for how we can work together to make the vision of access to care for all Chicagoans a reality. We have one final event coming up in our All in Chicago series, and it is free to attend. I encourage you to check out our website, allin-chicago.org, to learn more about the great event. It's held this month, and register to be all in. We all have a critical role to play in this effort. Thank you so much for being part of today's event.